All right. Welcome, Dr. Maria Kroll, to the Nurse Wellness Podcast. I'm so happy that you are here with us today.
Thank you for having me. I'm so excited to be able to be here and talk to you.
Yes. Can we start off by you telling us a little bit about yourself and your nursing journey?
So, first of all, I want to say that I was born in South America. I came here as a teenager and finished my education. I joined the Army because, I come from a family of six, so my parents couldn't pay for college. And so I decided that the way to go to college eventually would be to be in the service. Once I graduated, I had always wanted to be a nurse. If you go back to my yearbook, high school yearbook, you could see that my career choice was going to be a nurse. And I think about that, I had two choices. I think that I always say that if I was my mother, I would have been a lawyer or an FBI agent, but nursing was definitely a career choice. When I left the Army, I always tell people that I took probably the longest road. And that's one of the reasons why I think it's so important for everybody to have a mentor, but I think like for minorities is even more, especially because we don't really know, and our parents don't know which way to go in terms of achieving an education the easiest way. So I first, I was already married. I got married very young, and I, eventually went on to have kids. And I decided, my friend actually called me up and said, "I'm taking the LPN test. Do you want to do it?" And I thought like, oh, all right. So we took the test, we got in, and we started the program. And in retrospect, I always feel like I wish somebody had said to me, do an RN program, because this is 12 months, 5 days a week. And you could, and I had small kids at that time, you could really probably do better doing a 2-year program or a 3-year program for an RN. But I didn't know. So I did the 1 year, graduated, was in the workplace. And immediately I knew that I wanted to go on. And one of the things that happened to me that made me decide is because I think like people always think that if you're, Hispanic, or if you're Black, or if you're an LPN, that those are, that makes you less. So somebody said to me when I was working, was trying to give me an order, and I said, I can't take an order, I'm an LPN. And she said, "Oh, you're so smart," like indicating that only non-smart people became LPN. So what is a career? Why am I in this position? Is because it's not because I wasn't smart, it's because, this is the route I took. Anyway, so immediately I went right back to school. I found the program. The University of Bridgeport was offering a 12-month accelerated program for LPN. So I went back to Hispanic, finished my prereqs, got into UB, and finished my RN. So literally I was in school from like I should date myself, but for 1986 to like the end of 1989, like finishing up what could have been like a 4-year track, but just like a 2-year track. So I always tell people like really evaluate. I know that going the 2-year track is easier, but at the end, you end up in school 4-6 years to achieve something that you could have done in 4 years if you really just had the right mentor and somebody telling you really how it can be done. Anyway, so I finished. I had already been working in the hospital. So when I graduated with my RN, I went into the NICU to work in the ICU. And this is like in the early 90s. I think that I saw very little, the Hispanic population was not growing, at that point. It was still very small amount of people in this area that are of Hispanic descent back in the 90s. So I worked there, and around the mid 90s, I decided that I really wanted to finish my degree. I had always wanted to, and I think that I always believe in like education, because I want to, where we are is I want to be where I am because I choose to be there, not because I can't go anywhere else because I pigeonholed myself into like this, this is all I've done, I can't move on. So I went back to, and I was waiting around, I was waiting around for them to, I was lucky that I didn't have to take the GRE. I was waiting around for a program that didn't want me to take biochem because I didn't understand why I needed to take biochem. So the university, Sacred Heart University, began their program, and they did an RN to MSN. So I signed up, And so I completed my BSN and then my MSN, and I graduated like probably, I think I graduated in 2006 with all of it. And by then I had already left the NICU, because after like 10 years of working there, 10, 15 years, I began to feel restless, like I needed to do something different. I enjoy it and I still work at it. I enjoyed it, but I still wanted something different. So I had gone into case management, and that wasn't for me. And then I had a friend who was teaching, and she said, "Oh, they're hiring. Do you want to apply?" So I applied, and I got hired as a clinical instructor at first. In the meantime, during that process, during those years, I began to see in the early 2000s, the number of Hispanics were growing in the area, and they were coming to the hospital. And you could see, whereas before, I wasn't really, I speak Spanish fluently. So I, was needed occasionally. Can you translate? Can you translate? And this is before people started really being cognizant about using translators. I teach now, so I always tell my students, just because you can go to Taco Bell and order a burrito does not make you fluent, and you should not be attempting to talk to people who speak Spanish in your 5th grade Spanish. And no disrespect to people who attempt to do it, but I feel like we wouldn't do that to somebody who spoke German or somebody who spoke Mandarin. We would never even attempt to try to speak their language. But for some reason, when it's Spanish, everybody thinks that they should just do this. So I started to notice, that people really didn't go out of their way to provide the education, the care that they should, or mostly the education for people to be able to take their babies home and take care of them. So at that point, I joined the National Association of Hispanic Nurses, and I, started participating. In Connecticut didn't have a chapter. So I started traveling to New York City, and I would join their meetings. So I did that for a couple of years, and then I started teaching, and it really I started to understand more about the number of Hispanics, how we are not represented in education, how we're not represented in leadership, how minorities really, and, I've learned really very recently that, and I'm trying very hard not to use the minority term, because now it's become like, we're not less, and minority sometimes always implies that you're less. So, we are probably not the largest population, but anyway, so I started to realize how we didn't really have people of color joining nursing school, very, very few. And then they struggled with the program, and not because academically, I don't think that they're capable of doing it. It's because, we have different responsibilities at home. We have our families are very important, and they sometimes need to come number one and come in the first place. So I started to notice that was happening a lot, and there wasn't really support, and students would drop out really quickly because they just couldn't handle their family responsibilities, school, all at once. And because I was the only the only Spanish speaking person, the only person of color, students of color would come to me, and they would use me as their mentor, their resource. If they had a problem, they would come to me and want me to speak on their behalf. So then I started to notice that we really needed to do something about, mentoring them. And that's when I decided to start the National Association of the Connecticut chapter. So because I was a clinical instructor, had worked at the hospital for so many years, I knew people. And so I started targeting all my, all my gentes, I call them, all the Spanish people that I knew that worked at the hospital, talking it up. I talked it up to students. So I finally gathered like 10 people that were willing to do it. And we then became a chapter in 2010. And it's been really a great ride. I think we are now in our 12th year, or beginning our 12th year. In March, we celebrated our anniversary. And in the meantime, I've had the pleasure of like meeting, people like you, Wendy, and people from other disciplines and and mostly students who have been able to be part of the association. And one of the things that our chapter did initially is recognize that we needed to provide um, support for students, not only in terms of mentorship, in terms of networking, but also in terms of scholarship. So we created this fundraiser that due to COVID, we haven't been able to do it and we won't do it this year again, but we call it the tequila tasting event. And we raise funds and we've been able to give in the last 10 years, 15 scholarships to students, small amounts, but enough to help them with books or transportation or what have you. So aside from that, I feel like when it comes to students, we help them with mentoring, leadership, engaging in the community, recognizing, what we need to do. And I don't want to burden, I think that people of color already feel a burden to be responsible for all the health disparities that are going out there. But I feel that, we recognize them and, it's our people that are experiencing them. So we need to do something about it. So we've done, we have a community engagement committee that works on educating the public, especially the Hispanic community. Our motto is, promoting nurses to improve the health of the Hispanic community. So we've been able to do that. This year, we had a grant from the National Library of Medicine, and we've been doing health literacy education for adolescents in the community and also for adults, which has been really good. Another reason why too, I found important to start the chapter is because when I was working at the school had received a grant to do education, or the hospital had received a grant to do education in the community, helping people who had no, and this is before the Affordable Care Act became law. So people who had no insurance or minimal insurance, who didn't speak English, who had A1C levels greater than 8. So they hired me to do this. And so I would go into the community. My job was to go to make appointments with people, go to their homes who had been identified by their physicians needing education. So I went into their homes and, we talked about how they were handling their diabetes, in their kitchen, looking at what they were using to cook, trying to help them to change. Because, as Hispanics, we love rice, we just don't go anywhere unless it's accompanied by rice. So trying to show them healthier, and that they can still eat it, but that we shouldn't be eating it in a quantity, and changing their mindset about certain things, certain diets. So I did that for like a year and a half and had some really great results. I call it I think for some people, I was like their personal Weight Watcher person, because I would come to their house once a month with my scale and my looking at their books. Okay, let's look at your log. Let's look at what you did. Get on the scale. Let's measure you. And for some people, it really was very helpful. They lost weight. They began to walk and exercise and felt really good about it. So I took that, and it became part of what our chapter does. We did a program a few years ago where we had so in our group, it's not just nurses, is social workers, anybody who, I always say, anybody who wants to improve the health of the Hispanic community. And so we had a social worker, we had a nurse navigator, and then we had us, and we made a program where we would go to, there was some local churches in the city of Bridgeport, and we would ask for people who wanted to be part of it. So they would meet with us, and we would educate them on their diabetes, on their hypertension, on how to stay healthy. Then they would meet with a social worker who would then talk about, issues and things and help them navigate some of the problems. Because, if you say you have cancer, people immediately are, they can understand that. But if you say that I have diabetes, people say, oh, well, if you could just stop eating cake, you'll be fine. And because, and even for the person themselves, it takes years for you to see the damage that the diabetes has done before. And so I think that trying to make them understand how important it is to begin making the changes now so that we don't get to like the amputation and the kidney failure later on. So we, did that program for a few years. So we're always looking for programs that not only engage our members, but also, do something for the community. In in 2012, I left Bridgeport Hospital School of Nursing and I came to Southern Connecticut State University, where I, was teaching the nursing department. And I started a subgroup of our chapter with the students because I wanted to engage them early on to become leaders, to be mentored by us, and also to start engaging in the community. And 2 years ago, we changed the name. We used to call it the Southern Connecticut non-chapter, but we now changed it to the Multicultural Healthcare Leaders because we wanted to include everybody, because we did have members at the school who were Black, who were Brazilian, who weren't necessarily just Spanish, and they joined, and we wanted them to feel that it wasn't, like the name sometimes just isolates, people think, oh, it's only for people who's Hispanic. So we changed it to Multicultural Healthcare Leaders, and it has grown, and students participate, and we invited public health to be part of it. And so it's been in its 3 years now, and it's really working out well. And this year we have connected with the Southern Black Nurses Association and the Nigerian Nurses Association to bring them in to be between the 3 chapters to then mentor the students, because I think that it's good for students who are Black, African American, and students who are Hispanic to see people of their own heritage, thrive. And we know that, while we don't see it in practice in schools, and we don't see it in leadership, because I don't know if you attended the Future of Nursing, one of the webinars, they said that even today, 90% of people in leadership are still white. And so I think it's really important for students to see like the 2 presidents of these 2 organizations have leadership roles at Yale. So I wanted them to see that, that this is something that they can achieve. So it's been, really important, and the students have developed great leadership skills that they will take on, and hopefully, and I have some students who, continue on. We understand that there's like a gap in between graduation, getting a new job, passing the NCLEX, getting a new job, all that overwhelming, the night shift, that stuff that they're not used to. They think that school was tough until there's no spring break and they're, working. But so we give them a little leeway, and then then they come back to us and become part of as members. So we're always striving to help them. They're the future, and they need to know that they can make a change and a difference.
No, that is awesome. And you're doing such great things for the community, for aspiring and future nurses. And I think it's very interesting that it all stemmed from that one conversation when you were an LPN. And, it just kind of really changed your life, and you've been kind of going ever since. And now you are a doctorate prepared nurse. Can you talk a little bit about what inspired you to go back to get your doctorate, and how has having a doctorate really impacted your practice or your ability to influence the community?
So I want to say that when I graduated with my master's, I had said, if anybody hears me say I'm going back to school, they should immediately check me in and check me in, because I must have lost my mind. But, I was working, and I have a DNP, so it's a doctorate of nursing practice. I'm as people know, a doctorate of nursing practice is people who take research and put it into action. And then people have PhDs who love to do research. And I'm like an action person. I want to talk about what people have researched and put it into action. So when I was working at the School of Nursing, Bridgeport Hospital School of Nursing, the DNP started becoming something. It was just in its infancy, and people started talking about it. And I was like, oh, no, I'm not doing that. I'm not doing that. But then people that I work with started doing it, and I felt like, and my husband, and I want to say that my husband, we've grown up together. I mean, we got married when I was 19, he was 20, and I mean, he has supported me through school, and he's the first one to say, aren't you going back to school? Are you done? Are you going to do something else? So he was the one that said, you should do it. And so I was lucky that um, I had met somebody. I don't know if you know her, but Joyce Fitzgerald. She's a renowned author, and she is kind of like one of the few people. She's a Case Western, or was a Case Western. She started the DMP, and so she brought a cohort from the university, Oakland University, to Connecticut, and so I joined. And was it difficult teaching full time and doing it? Yes, but I feel like I'm so happy that I did it, because it has opened up so many doors. I wouldn't be here at Southern. I am now the undergraduate program director. I have, been able to, speak, on the topic. I teach maternity, so maternal newborn nursing is my specialty and my love. And so it has been, it has given me an opportunity to participate in, educational um, sessions with other colleagues. But it really has helped a lot. If I didn't have a doctorate, I wouldn't be here. And I feel like it did open up my eyes about getting programs, doing stuff. And that's one of the things that I do here too as well. I'm always like, okay, like we've talked about it long enough, let's put it into action. Because we can't talk about it for 10 years. We need to like move, like things need to change, and we need to make them happen. So it has helped. It is really, I'm one of the, I think that people know that I will always encourage education. Like, you should go back to school. You should do this. Take one course at a time. Before you know it, you're done, and it's like it's over. And as I mentioned earlier on, it really, if you love what you're doing, then you stay. But you know what? It's a choice. It's people in my generation graduated from nursing school, like a diploma. Maybe they got a bachelor's. They stayed in the same place and they never left, and so they feel like, oh, they couldn't do it. And I have not been like that. I have, I left the NICU, I went on to case management, I went into teaching. And in the meantime, I did other things, community grant work through, the hospital, things like that, because I feel like there's so much to do and not enough time to do it all.
Yeah,
So
you truly you exemplify the mission of the National Association of Hispanic Nurses, right? So really promoting furthering education and leadership opportunities. So you are really it. You are walking the walk and talking the talk, so to speak, which you don't see a lot. So as you know, we're currently in the middle of the COVID-19 pandemic. How has that impacted your position as a president of a minority nursing association, and what have you all done in terms of maybe addressing health disparities or educating the community in terms of, COVID-19 and vaccinations? Have you done anything in that realm?
So we definitely have. In early on in the pandemic, it was like a hard to shift from like on ground to um being virtual, and we, found needed to find our footing. But we're connected with the Connecticut Nurses Association, and one of the things that one of our members was doing early on is she's a public health nurse. She's a master's in public health as well as a PhD. And she is, speaks Spanish fluently. So the the Connecticut Nurses Association was looking for us to help with, because at the beginning of the pandemic, they were providing daycare for frontline workers, and the people providing the daycare were people of Hispanic descent in their homes. And they had a lot of questions about, what was safe, what wasn't safe, how. And so um, Dr. Planas, Jesse, was able to provide hour, like I think she did 2 hours a week, 2 hours a day for a, a space of like 6 weeks with these families, teaching them, how to clean, how to do disinfect, what to do, answering them questions about COVID. And back in June of last year, we still were going with, yes, this is it. No, no, this is not. Oh, let's change. And so that in itself was very hard for families. But I think like knowing that they were hearing from somebody that was like them kind of brought a little bit of trust, more trust in the message that we were trying to get across. So we did a lot of that. I started to bring in members, from the community into our chapter to talk about self-care and what they needed to do, and educating ourselves even more about COVID. And in the meantime, we had received our grant, which we were supposed to roll out in September, in person, going from to high schools, teaching adolescents about understanding how to obtain health information. So we had to pivot and immediately develop an online program and start targeting, which is what we ended up doing. And while it didn't start off, when we applied for the grant, it was just to do health literacy. It wasn't, but it became so important to tie COVID to health literacy, to help people understand where they needed to go to get the correct information, to differentiate between blogs and opinions and articles to like real scientific message, and to understand that this was new, and that while the message changed, it was because it was new. It wasn't because people didn't know what they were, scientists didn't know. It's just that this was a new thing, and every day we found new things. So we did that. We provided that. So it kind of worked out. The students at the high, I also had a grant for my students here and the multicultural healthcare leaders to do it. And their grant was supposed to teach adults about preventing the development of dementia through exercise, and then also health literacy. But because then we couldn't meet with any person who was elderly because of COVID, we then shifted it to just adults. And then it too became about learning about health literacy and learning about where to find the information on COVID. So that is what we have been doing since, the summer and September. And we still are getting calls from people who want us to present to their organizations. And in the meantime, we joined Yale's group that's working on messaging, to the community, putting out the right message. So I joined their working group, and we at the beginning met like weekly to develop like the talking points, making them so that people could understand them, at all levels could understand them. And now, and it's in September when vaccinations became available, we tried very hard to get in there and help out. But, with students, you really can't do it. And because it's run by the hospital, there's so many, you have to be hired and this. So it became a little frustrating. But in the last month, we have been able to join as not just, maybe not vaccinators because they're students, but as like drawing up the vaccines, herding the people in, helping. So we're doing that. We're helping people. We're especially targeting in the New Haven area, all these clinics that are helping in areas that are underserved. So we are doing that, and the students are really loving the being able to be part of it, to be able to say that they're helping the community. So that's our goal, to now that we're vaccinating more and more people, to be part of it, and to be much more involved. One of the problems, and I talk to people who are organizing, is that they have this stuff Monday through Friday, and people want to volunteer, but people work. So we said, if you had it on the weekend, you would have so much more people from our organization helping. And so at first they were like, we're working at, but I just recently got a message that they're getting a grant that will allow them to provide vaccination on the weekend, which helps with the community as well, because so many people just can't leave work. I mean, that's one of the things that I found interesting about COVID, and even from the testing, that we never really like, well, I'm grateful that it was rolled out, that people could get tested, that it was free, that it was available. I remember reading an article how when in New Haven, Yale announced that they had set up this big testing site at Long Wharf, on the Long Wharf section of New Haven, but you had to drive. And I'm thinking, it's away from people who don't have a car. They have to take a bus. What are they supposed to get in the car with somebody else? How are they supposed to get tested if you have to own a car? Like, we didn't, like, immediately from the beginning, not only were people of color affected by the number of people who were being infected because of the nature of the job, no, like most people in restaurants or cleaning or hospital employees who, are environmental services, had to work and they couldn't leave. I mean, so they're getting sick, but then here we are providing the service, but then we're saying, oh, you have to own a car. And, that in itself is a problem. So I think that, it became, I felt like it kind of like, it just never seemed to at the beginning be available to everyone. While they said it was available to everyone, I think that it was really not, because if you don't own a car, you couldn't go. And then also, I think like now with the vaccination, I follow this woman. She's a professor. Her name is Dr. Rhea. And she did an interview for somebody on TV, and people say that, oh, there's hesitancy among, Blacks and hesitancy among Hispanics. But I think that her message was really good. And I think I agreed with her that she said it isn't that it's hesitancy, is that it's not available. Like, it's not available. It's not that people are hesitating. It's just that they can't get it. That people are, there is distrust, obviously, and one of the latest things that we have done is members of our chapter have videotaped for this organization that covers, it's the Connecticut Task Force, Healthy Task Force. They videotaped themselves saying why they got the vaccine, which is helpful. So
yeah, no, that's awesome. And I think that's the importance of you being at the table, so you can say that. You're setting up this big production, but you're not reaching the people who actually need the vaccine. Right. And talking about hesitancy in the vaccine, it's not that, it's education. Even healthcare professionals, the scientists, we don't know everything about the vaccines or even the virus. So it's really education. Everybody keeps saying, oh, they're hesitant. It's all this and that. But we're people too, meaning minorities. We are people. We need to be educated and make sure we understand. Yes. And also access. So that kind of brings me to my next question about health disparities and telehealth. Everyone's talking about how telehealth is gonna, really be the end all be all for health disparities, which I totally disagree with. And I won't get on my soapbox because I want to hear your perspective, but health disparities is so much more than telehealth. I mean, that's not even the start of it. So what are your thoughts on health disparities and telehealth?
Well, I want to tell you my story, which will tell you what I thought. So my mom is 90 and she lives with me. At the very beginning of the pandemic, back in February, she had a doctor's appointment. Okay. And we got a call from the doctor who said we couldn't come to the office, that they were offering telehealth. So now my mother is, she speaks English. She doesn't really need a translator, but she's hard of hearing now. Her vision isn't all that well. So I said to her, oh, we can't go to the doctor, but we can do it on the computer. And she was like, what? Like, what is he going to do? Like, she already, we already, I don't know if you probably know this, how Medicare changed a while ago, where if you come to the office for your wellness check, you can't complain about anything, because then your appointment changes to an appointment and you have to pay. So my mother already is having a problem with that she can't tell the doctor, my back hurts, this hurts, because we're at the wellness check. So now she says, what are we going to do on the computer? So to her, she goes, I want to show him this, I want to show this. And she just didn't. She goes, who's watching it? Like, what are they doing? And she already had a hard time in person, let alone now we're going to be doing this. And, not being able to hear well made it hard. And so then what would it be? Me talking and me explaining? I think that, and my mom is lucky, no, she has me at home that I can, being a nurse, I can say the things, but too, at the same time too, I don't know if you get blamed for this, but sometimes people say that we're a nurse, because we're a nurse, we kind of poo-poo everything. So maybe I'm not the best judge of like who would be, but my mom, I don't think it would work. First of all, people who really truly experience health disparities probably wouldn't have access to a computer to do this. Will they? I mean, students already having trouble getting on the internet. There's 3 people at home going to school. They have limited Wi-Fi. Maybe they have one computer that they share. I and truly, like, can somebody? I mean, I think that if you have questions, if I want to, I think one of the things that I think is beneficial now is that, for instance, I don't know if you do my chart. Like, I can send a message to my doctor and say, I want to do this, I want to do that. And it goes and she responds, which I think is great. Like, I think that's great. But that's only because I can see my phone, I can read it, I can send a message. But my mom wouldn't be able to do that. Like, nobody, I mean, I think that people are saying, it's the end and be all of it, but it's not. Like, it really, for people truly who experience health disparities, who experience disparities, who are in areas where Wi-Fi isn't available, where computers are not available, where who don't speak the language, and who already have a hard time when they go to the office not speaking the language. Now imagine on a computer. And then, I don't know, I think that it doesn't address people's modesty levels. We have people who culturally are not going to, show their body off in a camera. So I think that we don't really think about, I just don't think that I think it's for younger people, for millennials, for people who have access. Yeah, this is wonderful. They can go on, they don't miss a beat, like they don't, but for people who really need to see the doctor, who have experience with, lack of access or lack of basic things, I don't know how it will work. And we know that, for instance, this whole time in terms of maternal health, so many women didn't go to the doctor while they were pregnant and missed out on great evaluations and great findings by the practitioners. So I don't think that, it's, I don't know. What is your opinion with it? Just give me a brief one.
Yeah, so I'm just thinking about, in terms of access, healthcare insurance. People don't have insurance, and telehealth is great when they say for people in rural areas, but what about people in urban areas, right? So people are working, may not have insurance. I think you hit on it. They may not have the technology, the internet, and computer literacy. How do you use this thing? If I do have the phone or internet, how do I use it, effectively? So I think there's just so many factors that go into telehealth that, I mean, I don't think they need to say anything about disparities in telehealth, because it does not start from there. It makes me crazy when people say that telehealth is really gonna, really help healthcare disparities in minorities, which it's not. It's
No,
not. I have a mom who's elderly. She has a smartphone. She knows how to answer it, barely, right? Never mind trying to get the doctor on the phone and all of that. But it just really, it
my
bothers me when people say that.
my mom has a flip phone, and while
Mm.
she has a Kindle, the moment the Kindle doesn't do like what she's used to doing, and it's because maybe the Wi-Fi got disconnected, she's like looking for me to fix it. So I can't even imagine somebody who doesn't have, somebody living with them that could navigate them. But yeah, I read an article, and I know I saw a grant. There was a I think the NIH or one of those groups was offering a big grant to develop telehealth for rural areas in Connecticut in terms of mental health. And so, I think that I did read, like, for people who have mental health, I mean, my mental health friends who are nurse practitioners have said that they find that people are more willing to meet with them, but then these are people who are younger adults. They're not, elderly who can't see, who may, maybe they don't have a tablet. I mean, who has a tablet? Not everybody has a tablet, not everybody has a computer. I think the assumption that every household has a computer and a tablet is really, another, disparity that we put on people. Like, we're already dealing with disparities in terms of access, insurance, getting the right provider to listen to you, to medicate you correctly, to, send you for the test when you should go for the test instead of waiting, making you wait. And now we're going to say, here, use your little, like for instance, with my mom, her flip phone to, to make an appointment. She can't even renew her prescriptions now because it's all online. So
Yeah, no, that's true. And I think telehealth is a great thing for healthcare in general. But when you talk about health disparities, just so much more there that we need to unpack before we start talking about we're going to, improve health disparities in minorities. So just to kind of switch gears a little bit, where do you see our profession in 3 to 5 years? And what can we do now to prepare nurses for that time?
I think that we really need to, I see us hopefully continuing on, what with, for years and years, we've been like the most trusted profession, but really, what does that mean? Where did that get us? We were still like, I want to say like second-class citizens when it comes to anything. I read an article recently that only, like, even today, only about 4 to 5% of nurses are quoted in newspapers or, interviewed to talk about issues affecting nurses and patients, and yet we spend the most time with them. So I feel that in 3 to 5 years, hopefully we have continued on with us being at the forefront and demanding to be at the table, demanding to be, heard and make changes in terms of, delivering the care or having people having access. In terms of leadership, I hope that we will not have wasted the whole, diversity and inclusion, the whole, what's happened in the last year in terms of Black Lives Matter, in terms of racism, that I don't want to think that we're just, putting a Band-Aid or paying lip service to it. That, like, this is a momentum and we need to, like, move forward and continue to make the changes, because until we have, like, when we look at a board of directors, I have to tell you a story. Years and years ago, I saw, and I saw Yale New Haven posted on Facebook a picture of their vice presidents and presidents, and they were all Caucasian. They were older males and women. So I commented, "Oh, nice picture. How about some diversity?" Of course, they didn't, and so then a doctor that I know of, Dr. Gata at Bridgeport, liked her comment, but they removed it, because it wasn't like that. But now we have a little bit more, there's a little bit more representation on their board of directors. So I hope that we will continue that until we have more, until we can look at a leadership and see that there's all kinds of people involved. And not only, I think, in terms of color or heritage, but in terms of, sexual orientation or gender, how people identify themselves. People need to be represented in all areas, because we can get better in nursing. I think nursing needs to change overall education to be much more addressing the people that we care for now, instead of trying to address how we have always done. Like, one of the smallest thing is like tattoos, like having a practitioner with tattoos or a student with tattoos, how we have to cover it up. Well, our population doesn't mind. Why does this people who are in charge think that that's something we need to get rid of? So I think, like, forward thinking, and I think that I think hopefully because we have younger nurses now going into the profession, we have increased the diversity, more males, more Hispanics, more Blacks, more African Americans. We, I think, have the power to make changes where people aren't dying unnecessarily, like because I teach maternity, I know like the fact that Black women fare, and you see it, fare so poorly. Even, we used to hide behind, oh, they're bad, they're poor, they're this or that. Well, we have I mean, I read, I don't know if you probably know that, 3 or 4 times higher people who are highly educated are dying. And yet, so what's the story? Like, what is the real reason? So we need to stop hiding, and people really need to come out and acknowledge their biases and do something about it. Like, stop hiding, stop saying, oh, I'm not biased. Oh, you're conditioned to be that. We're all conditioned to have some type of bias. And so we really need to work hard at like checking ourselves and saying, are we doing right by the patient? Or, I always tell my students that we're in people's lives for 30 seconds. So we're not there to change the way they are. We're not there to say, well, I do it this way. We're there to support them, to help them lead a healthier life and respect, but also to offer everybody the same kind of service, not differentiate between who gets what and who doesn't get what. Everybody gets heard. One of the things that bugs me the most is when I read like books. I teach transcultural issues in nursing, which is supposed to be about cultures, but I don't use a book because I find that I read these books that say Hispanics behave like this. And I'm like, well, I don't behave like that. That's not me. I mean, I don't do that. My family doesn't do that. We're also different within our cultures because we all have been raised differently. We all come from different, we have different mix, who has what in their family. And so I think that all of that, I think, needs to, hopefully we will move forward, because I think we really need to do it. I think that we have the power to be a bit bigger voice. And I think that nurses are now, which is not good for people who need care, but, young nurses are coming on, they're working 2-3 years and then going on for leadership roles, going on for further education, which I think is wonderful, because until we have that many who are not going to say, and, I think that this is a different kind of generation. And I don't think in terms of like age, but like a generation in terms of generational nurses, where they're not going to stay around if you're not going to treat them right. So I think that is, people need to be, checked. People need to really, employers need to hear that nurses do make a difference. And I know that COVID has shown that without nurses, they wouldn't have been able to run. And some nurses, are suffering greatly because of this. As you might know, they are unbelievable. I recently, I work at a local hospital, and we had a nurse who was working in the city and delivered here in Connecticut, and she had taken a leave and was on Prozac, and because she was so devastated by what she experienced. So I think that we owe it to them to really change the way, because while we were there to help, and we, as always, when we're called, we come, nurses, I don't think that we get the respect and the recognition that we need more than just to show up to work. We need to have power. No, and I think it's going to happen. I think people like you who are in the profession, who are making a difference, all the other practitioners and new nurses really who seek leadership roles, hopefully will make a change.
Yeah, we have to be the change that we need. And, post-COVID, PTSD, mental health, physical health of nurses, definitely going to take a hit. So we need to be well, really take care of ourselves so we can be at the table and make effective change that's going to impact how we practice, So I totally agree with that. And nurses, I always say this, are so powerful. We just don't know the power we have, but we are very, very, very powerful. So we're going to wrap up and do our rapid fire. Are there any last words you have for our listeners before we wrap things up?
I think that people need to realize that, as you say, we have the power, and we need to really exercise it. And I think it's time. I always say that there's two types of nurses: the nurses that punch in, do what they need to do, and they do a great job, and then they go home and don't think about it. But we need nurses to be involved politically, to advocate, to be at the table. We need to be Mrs. Underwood. We need to be, all of us need to be, maybe not at the high level, but we need to be supporting all these causes that are out there to improve the health. Because I think that when we improve the health of, for instance, Black maternal women, then we will improve the health for everybody. It's not just it doesn't just affect us, one group, it affects all of us. So advocate, be present, speak up. Don't take us, we're not subservient. We should just stop being that. We're nurses, and we're professionals, and we're educated.
Awesome. Thank you so much.
You're
All right, let's get into our rapid fire. So please
Okay.
finish these sentences for me or answer the questions with the first thing that comes to your mind. Wellness means,
Being healthy.
I know I'm stressed when.
I have a big headache.
My go-to stress management solution is.
Read romance novels.
The last time I had a belly laugh was.
Mm, I don't remember. I was away last week in California with my grandchildren, and my granddaughter really makes me laugh.
Awesome. Awesome. One thing I learned about myself during the pandemic is.
That I'm okay to stay home.
Me too. What is something that people get wrong about you?
I think that they think that I'm bossy.
And what is one thing you're grateful for today?
Oh, I'm grateful that we met. I'm grateful that I have this opportunity to speak here, that to have myself for people to hear what I have to say, and that you think that I'm interesting enough. We always suffer from that imposter syndrome where we think like, what could I say that people would find interesting? So I'm grateful for that. I'm grateful that we connected.
Awesome. And I'm grateful for that too. And thank you so much for being here. We'll have to have you back again sometime.
Thank you. Thank you. It was I can't believe it went by so quickly.
Yes.